We are honored today that we have a special guest speaker, Dr. Kishore Iyer. Dr. Kishore Iyer is the Director of Adult and Pediatric Intestinal Surgery and Transplant at Mount Sinai Medical Center in New York City. He is a Professor of Surgery and Pediatrics at Icahn School of Medicine. Among his many credentials, he is a Fellow of the Royal College of Surgeons in United Kingdom, as well as a Fellow of the American College of Surgeons. He is one of the world's most renowned pediatric transplant surgeons. And I would say that he has probably saved more lives than perhaps breakfast that I've had in my life. He is also he trained in UK in pediatric surgery. Then he was at Chicago and then in Omaha. Now, wanted to mention that his research at the Great Ormond Street Hospital for Sick Children in London was the 1996 British Association of Pediatric Surgeons International Prize winner. This was heralded as one of the most pioneering work which can identify potential cause for intestine failure associated liver disease. He does broad research in the area of intestinal failure and transplant, as well as development of intestine failure things. Now, the reason we are inviting him here is that for him to talk about how he saw addressed the issue in the field of intestinal failure and transplant, which is very similar to the issues we face in Enterprise Neurosystem Group. He is highly specialized, one of the world's best and most renowned people, and his skills are needed throughout the world. But there are very few people with this type of skill. And in order to help a broader segment of population, he started this program called Lift Echo. The model and the approaches of that program seems to be something ideally suited for our own and used within the Enterprise Neurosystem Group. So I wanted to have him share with us how he does that, his experiences, and basically essentially use that as a as a medium for seeding discussion about how we can we replicate that model to help with the activities of Enterprise Neurosystem Group itself. I also wanted to mention that when Kishore is not saving lives with patients with intestinal failure, he has a very eclectic taste in music, and then he is one of the avid motorcyclists. He has probably traveled to across the Andes range and across the United States and Canada and various places on his trusty motorcycle. So if you guys are interested in motorcycling, you'll find experienced pediatric intestine surgeon, transplant surgeon to ride it with. With that, I want to turn it over to Dr. Iyer to talk about the Lift Echo model.
Thank you very much, Dinesh, for this for that very generous introduction. And I should confess right at the beginning that I took this invite with a little bit of apprehension, because anything that says intelligence in its title worries most surgeons, as you can imagine. It's not completely a coincidence that some of us enter surgery, but I'm curious about things other than surgery. And Dinesh and I were chatting about your pretty ambitious and laudable project. And as we were discussing what I was doing, we thought there might be some commonalities, and perhaps the model could be applied to solve a similar issue that might be at hand for you. Let me see if I can advance my slide. So I'm cognizant that none of you, to the best of my knowledge, is a physician or a clinician. So I'm going to keep this relatively brief vis-a-vis intestinal failure. But just to set the stage, you're probably all familiar with kidney failure, cardiac failure. Intestinal failure is a somewhat more obscure disease, but think of it as end organ failure affecting the intestine, where the intestine fails to perform its usual functions that you could imagine. As I said, it's a very rare, it's a very complex disease. And over the years, I've been involved with intestinal failure, now coming on to well over 2 decades. And there have been recurring themes of problems of distance, of geography, certainly in the US healthcare system, problems of insurance. And all of this leads to challenges for patients to access expert care. And the evidence for this has been difficult to bring together, but we have in recent years made some attempts at demonstrating that the problem is real. So we published evidence for lack of expertise in intestinal failure recently. We showed that patients have to travel long distances for expert care. And we've recently turned up some evidence that this lack of expertise actually leads to poor clinical outcomes. And this brings us to the somewhat fundamental question: should the intestinal failure patient, say in Montana or Idaho, you name it, have the same access to expertise as the patient in New York or Cleveland? This is just a few illustrative slides to show you the magnitude of the problem that we were trying to address. This was a paper that a few of us did sometime early last year, and this was based off, and you can imagine the challenges even to identify the problem. Intestinal failure as a diagnostic code does not exist. So this was data that we obtained by analyzing a very large third-party insurance claims data set, creating a logic code to identify patients with intestinal failure nationally. And here was one metric that showed that patients had to travel very long distances to get their appropriate prescriptions for care. This is work that is currently still in progress. I'm working with a data analytics group at Optum Healthcare, a familiar name to most of you perhaps. And what we showed was that there was real fragmentation of care nationally. This is US claims data. We showed there was real fragmentation of care. And as you can see from here, there appear to be surrogates suggesting that this fragmentation is leading to poor outcomes in this particular slide, as evidenced by visits to the emergency room or inpatient hospital admissions. Look at that small inset there. One patient over a 3-year period had 94 visits to the emergency room. One patient had 31 inpatient admissions in a 3-year period. While we can't show causality, it certainly suggests that there is a problem. So without belaboring the intestinal failure question, what we're trying to address was the issue of, can we do anything about this problem of inequity in access to expertise? So what is the issue? And pardon the somewhat basic graphics here, but irrespective of field, it's no overstatement to say that specialized knowledge is growing, and assuming there is finite capacity to learn for some of us, including yours truly, perhaps that capacity is even more finite, but it's really hard to keep up with the seemingly exponential explosion in knowledge. Project ECHO stands for Extension for Community Healthcare Outcomes, is a very novel tele-mentoring program launched in 2003 at University of New Mexico by Dr. Sanjeev Arora, a liver specialist, a hepatologist, to address disparities in hepatitis C care. And I will just digress for a moment to point out that hepatitis C, in terms of frequency, is at the opposite end of the spectrum compared to the problem I was trying to solve, intestinal failure. Hepatitis C is a very, very common disease, widely prevalent, globally prevalent. And when Sanjeev first came to New Mexico as a newly minted hepatologist, he realized that he was actually the only such expert in the state of New Mexico. He was the only liver specialist in all of New Mexico. And the wait time to see him very rapidly got greater and greater until hitting a peak at about 10 months of waiting to see this one expert. And Sanjeev quickly realized that this was not tenable. And he then launched Project Echo with the goal of connecting multidisciplinary teams of specialists with non-specialist primary care providers at community clinics across New Mexico. And thus came the now popular sentence in echo circles, at least, that the goal of Project Echo is to improve outcomes by moving knowledge, not people. And I will ask you, as you're thinking about this, just substitute hepatitis C or intestinal failure with your own uh, domain of expertise and your own problem of disparities in access to such expertise. So it doesn't matter whether the domain is hepatitis C or intestinal failure or artificial intelligence or climate change. I've taken a look at your very good website. So whatever the problem you're trying to solve, the platform could really be the same. It is expertise that is the premium that you're trying to distribute on that platform. So how does the Echo model work? Sticking with very basic graphics. This is an original graphic. In fact, they've updated the website now. And I would suggest for anybody who's interested to visit the website of Project Echo from the University of New Mexico. That's really the mothership of the Echo model. So the ABCDs of Project Echo: A, amplification using very simple, now ubiquitous video conferencing technology to leverage scarce resources. B, share best practices to reduce disparity. And C may or may not apply to you, but is well recognized in medicine that most of us really become good at what we do by case-based learning. We're not big into theoretical reading, but you read, you then see a patient, you see a case, you understand the case, you solve the case, you get some didactics, and that leads to steadily increasing knowledge in the specialty. And Sanjeev was quick to realize that this activity had to be monitored. You had to have a database to monitor outcomes, understand what it is you were doing. And as I've recently said to Sanjeev, he's missing the E, which I think is really important. You have to build in upfront evaluation metrics so that you understand the impact of what you're doing. And that has actually now grabbed a lot of my own attention. Dinesh failed to mention, I'm actually in school at the London School of Economics, trying to understand how does one formally go about evaluating large-scale health interventions. But at the end of all this, what does ECHO achieve? ECHO uses these principles to create virtual communities of practice. You'll hear that term over and over, virtual communities of practice for people who wish to engage in a process of collective learning where knowledge is shared, innovation is cultivated, and problems are solved. And for those of you who are interested, I've just put down there some of the early landmark publications in this regard. So at its core, how does ECHO work? The model is sort of horizontally dispersed. All teach, all learn. It's not hierarchical, but it does follow a hub and spoke model, with the idea being that the experts constitute the hub and the spokes are the people out in the periphery. In the context of intestinal failure or hepatitis C, these are non-expert clinicians who we're trying to help manage their patients. So your context might lend itself to different spokes. And what does the hub need to make this all happen? Every ECHO needs one invested lead facilitator, somebody who owns the ECHO, needs a program coordinator who keeps track of the operational pieces. You need some IT support, and then you need subject matter experts who bring in the expertise into this common platform. I'm not going to speak to this slide, but I'm going to let it hang there for a second illustrate what are really quite intuitive ideas for why this works. There is, and some of you may shudder and say, what is this joy of work you talk about? We know not. I sympathize with you, but there is a joy of learning. There's a joy of improving. There's a joy of doing something for the greater good. And there is a force multiplication, and if time permits during discussion, I will share more about this, that ECHO creates. It's quite a democratic learning platform that is wonderful to see. And I don't know if this is the right slide for me to say that, in case you're wondering, wait a second, you're just talking about a Zoom platform. Oh God, not one more. We do enough of these. There is a difference, subtle but important. I think what ECHO has done, and think about this, ECHO was launched way, way before COVID, way before every one of us became a Zoom expert, to create this virtual learning platform where the mantra is all teach, all learn, and a term that we don't often hear, democratizing knowledge for the greater good. And we can speak more about this. This is just a couple of quick graphics from our first ECHO, and you can see that just looks like a regular Zoom platform. And I've put down there the anatomy of an ECHO. How does ECHO work? And this is just the anatomy of our ECHO. Yours could be modified, could be tweaked, but ours is very strictly a 1-hour program. People don't have too much time in their busy lives. And in fact, if you think about it, to ask a non-specialist clinician, what is your greatest commodity that's in short supply? It's an hour of time. I'm going to hold there for a second because I see a raised hand. I'm happy to interrupt and take questions now or come later. Joe Noonan, I don't know if you're...
Joe, you have a raised hand. Do you have a question?
No, my apologies.
No worries. The hand disappeared. I hopefully will have plenty of time for questions, and I hope there are plenty of questions, because certainly this is applying ECHO to something non-medical is at the minimum interesting and piqued my interest for sure. So this is the anatomy of our ECHO, how we run our ECHO. There's obviously a few minutes of housekeeping and introductions and some ground rules. We uniformly, we maintain quite strict fidelity to the original ECHO model. So we have somebody from some remote practice present a case, and I'll just emphasize, at least in the context of healthcare, this is fully HIPAA compliant, so there's no confidential information that's released. This is no different from, imagine a virtual grand rounds in an academic hospital. Somebody presents a case, I facilitate discussion, and while that looks quite structured, it is less so now. And the best ECHO sessions I run are the ones where people are jumping in and saying, wait, I don't agree, or I agree, that's wonderful, what do you do? And the lively echoes. And in a way, that is both the challenge and the opportunity. If you're not careful, and if you're not good at it, it'll sort of devolve into just one more webinar, and people are doing other things or planning their evening social engagement. The lively echoes are the ones where it's very dynamic. There's a lot of to and fro. There's some chatting going on. People are, we have some polls in the middle of all this just to keep engagement going. And we end every echo with about a 20-25 minute didactic lecture from a global expert who speaks on a topic of his or her expertise relevant broadly to intestinal failure. And sort of as a service to the community and an incentive through grants we've received, we provide, and this may not be relevant to you, but we provide what are called continuing education credits for non-academic physicians. That's an important requirement that they often pay money for. And so we provide the continuing education credits. And then what I also do is we archive all our didactic videos on our website. And of course, because I'm obsessive compulsive, I track how often people are watching them. Just to give you quick snapshot of what our echo looks like now. We do them in modules. There are different ways to skin that cat. We do them in modules. And you can see at the very first echo session, we had 14 participants. Our average participation for module 1 was 44 different sites, not individuals. By module 6, we were up to 159 sites. And we started getting international participants. And there's our geographic reach within the first 6 modules. So very quickly, we got across most of the mainland US, in fact, also from Hawaii. And now participants from 6 of the 7 continents. Of course, nothing like a good wife to keep you right. And my wife said to me, what happened in Antarctica? How come you're not reaching Antarctica? But you can see the reach of something like this. We can, and I'm going to come to this in a second, so just take a quick glance at this slide. Obviously, we are in mid-21, I've not updated this, but in mid-21, we looked at what was our viewership of videos, how many people actually finished their videos, what's the breakdown of disciplines, and of course, we wrote about it. But I want to put that up there for a second. And if you look at the authorship of the first paper, that includes clinician experts, physician experts, it includes research coordinators, it includes a technical operation person, it includes a couple of PhD nutritionists, it includes a representative from our professional organization who helps manage the continuing education credits. It includes, and this was, if I say so myself, remarkably insightful of me, it includes the national medical directors of 2 major health insurance companies. It includes our patient support organization, and it included Sanjeev Arora, the founder of Project Echo. And I want to give you some idea of what is the reach of Echo itself. I mean, this is, at this point, unequivocally, Echo is a movement. It's been adopted by almost 800 of the world's leading academic medical centers. I'll tell you, I collaborate with a evaluator at the CDC, and she was telling me that the CDC, some of you may know this, CDC runs many different HIV efforts in Africa, and they have 10 different echo projects going on to evaluate their activity in Africa. So echo is a movement in healthcare. What has that got to do with the price of fish or artificial intelligence? So look, echo is not just for health. I've tried to make the case in the limited fashion that I know how, that it almost doesn't matter whether you're discussing intestinal failure, or you're discussing hepatitis C, or you're discussing climate change or artificial intelligence. There are multiple examples of its use in public education, K-12 education. Police forces now, several police forces in the US are using it to disseminate best practices. So I think you're limited only by your imagination. You've already guessed this, nothing special here. Routine video conferencing hardware. Long before Zoom was a force to reckon with, in its early days, Zoom and the Echo Institute had a collaboration, and Zoom continues to honor that collaboration, and provides free license to every single Echo project around the world, which is, of course, especially relevant in low and middle income countries. Video conferencing software, recording system. There's a Project Echo resource library that has, very often you'll find if you're trying to crack a problem in Echo, somebody else has thought about it before. And Echo, this is still evolving, and I think evolving to a very good place. It's an electronic Echo session management solution. And one of the things that Dinesh and I discussed as we were talking about this is really what Project Echo has done is it has really operationalized conducting this knowledge, managing this knowledge exchange forum in a very uniform and reproducible fashion. I echo this. We don't yet have the latest iteration, but it's coming soon. But I've already given you some hints of what we can do with it. You can manage the scheduling, you can manage attendance capture, you can automate reminders, you can certainly track your outcomes, and that's iEcho available within the platform, obviously at no cost. So look, this was going to be my segue to wrap up, and I'm happy to join this effort, even as a fly on the wall, to let you discuss how it applies to you. Happy to weigh in with what I know. And I will tell you before I go to my next and last slide, at the current time, I've talked to Sanjeev a couple of times this last week, and I'll tell you, between an evening, we talked on an evening, and there were 905 active echo projects around the world. We had to talk the next morning, and he said, will you believe it? Between the time that you and I went to bed and woke up, there are 5 more new echo projects. So in healthcare, it's a movement. But one of the things we've realized is of the 900 plus echo projects, less than a handful are in surgical disciplines, and you can imagine why that might be. So I'm now involved with the London School of Economics and the Royal College of Surgeons. We just got funded from a not-for-profit in the UK to test out applying echo to strengthening pediatric surgical systems in Somaliland. And so obviously the generic model has to be tweaked a little bit, perhaps a little more for your needs than for ours, but it's very much doable. And as you think about, could you use this? Would you, perhaps more importantly, should you use this? Here are some of the questions that might help inform that discussion. What is your subject matter? Is that one uniform subject matter of sufficient interest? Who are the experts? And I will tell you, as I did this echo project, I was challenged by that question. Why am I an expert in intestinal failure? Because Dinesh generously said so, or because I've written 100 papers, or what makes me an expert? So we actually, last year, a year before last, we created, just to answer that question, we developed a knowledge test in intestinal failure. We validated it. I learned more about test construction and validation than I ever thought I would learn. And we showed that the test could distinguish between experts and non-experts in intestinal failure. And then for good measure, we partnered with an online medical education company and deployed it to 100 US gastroenterologists. No surprise to me, we could show that the vast majority of US gastroenterologists are not experts in intestinal failure, including the 50 or so who identified themselves a priori as experts. Go figure. I'm clearly not getting any Christmas cards from US gastroenterologists. But I think these are important questions. Who are the experts? Are you the experts? Is this uniform? You have perhaps limited domain expertise. You're very good in what you do, but there are other areas you would like to know more about. Who are the learners? And is the notion of expert and learner not even relevant to you? How do you connect these people? Who's the host? And you do need to think of a physical host that runs the echo, but then the virtual host is the hub, the collection of experts. And then what is your goal? And I will tell you that the original goal of the ECHO project was to improve outcomes by democratizing knowledge, making non-experts function at the level of experts. And we've learned, we're in the process of doing a mixed methods evaluation of our pediatric echo, and we have a little suspicion. We're not actually changing outcomes, or at least not yet. But what we have done, and done robustly, is we've created a community of very engaged and very enthusiastic learners. If we take a hiatus, I start getting the emails. When are you back on? When are you back on? And that may be in and of itself a satisfactory goal. With that, I'm going to stop and look forward to discussion if time permits.